Perfect. Awesome.
Thank
Well,
you.
thank you everyone for joining. We've got a great group here today. In introduction, my name's Claire Meunier. I'm the Chief Operating Officer of the Digital Medicine Society, and really pleased to be with everyone today to share these new resources and have a really robust discussion about what we're doing, about what we've been doing here in Impact. I want to start with some quick housekeeping notes. Today's session is being recorded, and the recording will be available after today's session. Also, some quick instructions. If folks have questions, we welcome you to drop those in the Q&A function on Zoom, or you can raise your hand and I'll call on you. We'll try and save questions to just after the panel, but please feel free to drop them in as we go along, because when we get to that Q&A portion, we'll be eager to talk through that. I want to start with a bit of a level set to really just be really clear about what we mean when we say virtual first care. The Impact Initiative has done some significant work on getting this concept defined. We're really talking about medical care for individuals or community access through digital interactions where possible, guided by a clinician and integrated into a person's everyday life. You'll see here highlighted 4 key features that we see consistent across every virtual first care solution out there, but we really are talking about front doors and longitudinal experiences that are at least mostly virtual, if not entirely virtual, in terms of how they're providing care for patients. And that's an important kind of cornerstone of everything that we'll talk about today. And so we felt like this was an important grounding for this conversation. So in terms of today's agenda, we're going to hear from 2 experts in the field who we're really lucky to have. They're going to make some comments from the virtual first care solution perspective, integrating also some of the payer perspective. And then we're going to go to some of our Impact members and really talk about these new resources, how we're going to put them into practice, and what the opportunity out of this is today. So now, without further ado, I'm really excited to introduce you all to Impact's co-founder, alongside our colleagues at the American Telemedicine Association. Don Jones has been at this health tech thing for decades now, starting in his role at Qualcomm Wireless, where he led the global strategy and founded their healthcare subsidiary. He is a globally recognized leader in the field of digital medicine, digital therapeutics, technology-enabled healthcare, and has really come to specialize over the last few years in virtual first care. Don is working as an advisor, as a consultant to, I think, 30 or 40, I tried to count on LinkedIn the other day, different companies. And so we're really, really pleased to have Don here to sort of take it away. So Don, I'll let you share some of your thoughts.
Thank you, Claire. Thank you very much. This is a big day. It was only 9 months ago that I approached Jen and asked her if she and Dime would be interested in leading an effort to bring together the resources and necessary to help the virtual first industry take off. I was already seeing the virtual first industry being born, and I knew it needed a lot of help, and the companies could learn and grow from each other. So that was the birth of it. We launched at JP Morgan in January. And so this is an important milestone because obviously this represents the flag in the ground around model contracting and payment structures, which obviously is a major cornerstone for the virtual first industry. Interestingly enough, virtual first is not new to me. I think I have the advantage of effectively playing in this field for my entire career. I started out, some of you know, in emergency medical services. That's not necessarily a virtual industry, but it is an industry that delivers medical care and intervention within 8 minutes of a customer request. And outside of an ICU, I can't think of any other place in healthcare where an immediate need is actually met. So I grew up essentially building what became the world's largest company, EMR, in emergency medical services, that focuses on delivering answers to consumer needs in 8 minutes or less. And this led me to come to the conclusion that this industry that says, can we bring everything that the patient needs to them until you can't, is an interesting thesis. It's an interesting thesis for investment. It's an interesting thesis for payers. insurers to offer. It's an interesting thesis for consumers to demand and expect. And it's an interesting thesis for healthcare providers to operate under, especially because it gives healthcare providers so many new options as to how they can actually work. It opens doors to healthcare providers that may have young children at home. It opens doors to healthcare providers that may be disabled or looking to retire, and they can still be active and participate in their chosen fields. My very first virtual first company, for some of you who may be aware, is a company called MA. I launched it in 1993 in Mexico. MA combined telehealth together with house calls, together with walk-in urgent care. So it had a bricks and mortar component as well in a consumer membership model. And while we didn't set out to do this, within 3 years, we had built the largest private practice in Mexico, in Monterrey, and I had almost 500 physicians working for me in that company, offering effectively a virtual first lead kind of offering. And almost a third of the entire population of the city of Monterrey, an area with 3 million people, were members of MA for that virtual first services. Then later we saw companies like Hims and Hers, and lots of companies that combine professional services with prescriptive drugs that were easy in the areas of ED and birth control and hair loss and many, many, many other things. Very simple concepts, but obviously taking off and growing, and many becoming unicorns very, very quickly. So this has now led to a really interesting environment of funding. And I personally have seen 3 different companies close rounds this week alone, and I'm working on 4 other companies that are working on their rounds at this point in time. So I personally am living kind of this environment where we've got a lot of investor interest, a lot of payer interest, and a lot of interest from providers and entrepreneurs to bring virtual first to the industry, to the marketplace. So there's lots of reasons to build virtual first companies. But I personally think the biggest reason to build a virtual first company, besides the obvious ones of making money and filling niches in the healthcare delivery space, is the fact that I think everybody has aspirations of becoming bigger providers, providing care to more people, providing better access to more people, and perhaps becoming a nationwide or even a global company. And frankly, we don't have very many global companies in health, or now even national companies in healthcare services. There's a few: DaVita, Fresenius, American Medical Response, my old company, Kinder. They're close to national service companies. But when we look at hospitals, there are no national health hospital companies. There are no national medical groups, even the big ones like Mayo and Cleveland. Long, long, long way from being anything that could be considered national. And yet Virtual First offers the opportunity to begin offering services on literally a large region or national or even ultimately global basis. And I frankly think that's the big opportunity and the big aspiration and the big need that can be met, as access can now be granted to folks that may not have previously had easy access based on where they live, or how close they are to various services and high quality services. On top of that, we now have new therapies that are being designed and evolved. Diabetes is probably one of the areas with the most active set of tools, so people can self-manage their therapy. But I think we're going to see that grow in many other therapies as Virtual First basically drives the need to drive more easy to use the diagnostics and therapeutics that can be self-managed by patients. So that's another opportunity that's directly related to the whole Virtual First movement. And then finally, we'll even have a CMS joining in as they're starting to think of and announce things like remote therapy management, which is payment for another version of remote care on top of chronic care management and remote patient management. So all of things are coming in line. I think the stars and the moon and the sun are all coming into alignment. We've got a great deal of opportunity in front of us. This is a big step towards those goals. And I really have to thank Claire and Jen for leading this effort. They've done a fantastic job. It's one of the best management groups I've ever worked with in kind of the trade industry space. And I really want to thank both Jen and Claire and the teams there for pulling this together. And I'll continue to help support them. So with that, my message is go forth and create. And let's all work on improving healthcare and improving access and ultimately improving health. And I think Virtual First is an excellent tool to get out there and do it. Thank you.
Awesome. Awesome. Thanks so much, Don. Excellent perspective. And I think you set the stage really nicely about how, the constellations seem to be right in the sky here for us to do this and really drive meaningful adoption. I'm now really pleased to introduce another expert that we're very, very fortunate to have here. So Dr. Sarah Bhatnagar is currently the Chief Health Officer at Payer. Sarah brings to us this incredible deep knowledge and experience in medicine, technology, human-centered design, and quality to drive healthcare innovation. And he started out as a software engineer, turned physician, turned educator, and now business executive. He's worked across the sector on the strategic path to delivering better interoperability in healthcare. He's held executive leadership positions at the VA, faculty at Harvard Medical School, and most recently, before his tenure at Payer, was the chief medical officer and the head of digital and technology at United Healthcare Group. So we are really, really thrilled to have his expertise here and his perspective, bringing some of his experience in the payer realm, as well as his broader experience across the ecosystem to this conversation. So with that, Sarah.
Thanks so much, Claire, and thanks, Dime and ATA for having me. And let me start off and echo one of the elements that Don just mentioned in his opening remarks. Whenever I think about virtual first care or virtual care in general, is really about access, right? And so as a physician, I'm a physical medicine and rehab physician, a traumatic brain injury subspecialist. So being in that subspecialty area, oftentimes it is for patients to be able to come and see me, it is all about access. So when I think about the broader healthcare ecosystem, especially as a rehabilitation doctor who's been in inpatient facilities and emergency rooms, in ICUs and outpatient facilities, whether it's rehab or subacute rehabs or long-term acute care facilities or in-home care, frankly, I think the opportunity that we have in virtual first care now and what you all have been working on, and I'm excited to kind of hear what the panel has to say after my remarks, is really that element of access. How does virtual first care really enable access for healthcare in the United States and healthcare globally? So from my different vantage points where I've had the opportunities to really help the healthcare ecosystem, both at United Healthcare and at VA, two very different systems. One, VA being the largest provider in the United States, serving veterans across all 50 states, national footprint, lots of different geographies. So some of the stats that I think really virtual first care could have helped me in some of the problems that I was trying to solve from that space was the number of veterans that live in rural parts of the United States, the number of veterans that don't have internet access. And there's some very interesting statistics which may have slightly evolved and have to be updated post-COVID, but at least pre-COVID, some of the statistics were that about 20 to 30% of veterans lived in rural parts of the United States. So when you think about access, and even in my own clinical practice, when I would see a veteran, and I practice out of the Boston VA at that time, I would have veterans driving from Maine or from New Hampshire. So 4 or 5 hours to come see me as a traumatic brain injury specialist for some access to care. So when you start thinking about virtual first care, it starts to really unlock different ways to access for those individuals, the healthcare ecosystem more broadly, and try to bring healthcare to a more local and more easily accessible fashion. Because healthcare, and especially what we talk about at Payer, thinking about health assurance, it's not just about sick care, but also about well care. And how do you really enable well care? You have to make it easier for people to be able to access those types of services to really be able to enable what we want to even work on at Payer, and what we've been working at Payer at is well care. And so rural versus urban environments, that's one of the areas. The other is folks that have access to digital health services or may not have access to digital health services. And I think that's something that is still an opportunity and still a challenge, not just for the healthcare ecosystem to solve, but partnering with other ecosystems in the United States to really solve. Another interesting VA stat. About 25% of veterans don't have access to internet within their homes. So thinking about how do you solve the problems of virtual first care for those types of individuals, not just veterans, but and in this forum, you're talking about veterans and non-veterans. So just overall for the healthcare population, not just in the US, but across the globe, thinking about how do you provide access to some of these virtual first services in an equitable manner, and what other support systems are needed, not just from the healthcare industry, but across other industries to really enable some of that, I think is an opportunity and a challenge that I had to solve in the past, trying to really push and deliver virtual types of care services in various systems. So I think that's, to me, an interesting data point from the past. The other data points that are very interesting is thinking about different market segments that are really interested in virtual first care and trying to evolve some of the thinking that I would generally hear about. So an interesting statistic from my days in working in the Medicare space was, and this was some great research that you all should read from AARP, and they put a lot of this information out there every year of thinking about how to engage patients and members, persons over the age of 50 in the healthcare ecosystem. And in the United States, we have over 10,000 individuals aging into Medicare every single day. And so this is going to be a continuous growth population of thinking about how do we serve many of these members who are have maybe single disease conditions or complex disease conditions in that virtual first environment. I think there's a lot of opportunity and greenfield to think about how to be able to deliver some of these services in that environment. And the statistics that I would always have to counter with a lot of the digital health companies that would work with us would be, Medicare members may not want to be engaged, or those above the age of 50 or 65 may not want to be engaged. And I think that's the counterpoints that you see in the statistics that AARP puts out, and other membership services have put out similar types of statistics, is over 80% of, at least this is US data, so over 80% of those over the age of 65 have access to smartphones, and over 50% use those smartphones every single day, but not for the purposes of healthcare, right? And so what can we do in terms of the healthcare industry to really make and enable that to be an easier experience? There are goods and services, other vertical industries that those members over the age of 65 are using their smartphone every single day for, whether it's connecting with their loved ones, whether it's doing online financial or banking statements. Are there elements that we still need to go and improve in the healthcare industry? And the answer is yes. If you're just wondering, the answer is yes, of making that experience much more easier and much more accessible. And this all ease translates into access. And especially as a provider, when I think about sort of the brick and mortar clinic, if I add a lot of barriers, say the parking lot is a 5 to 10 minute walk, and then check-in at clinic is a 10 to 15 minute wait, and then there is another 10 to 15 minute wait. In that physical environment, those are all barriers of patients wanting to have easier access into services, and may not have them coming back, especially in the primary care field, may not have them coming back for some of those preventative services because it's inconvenient, or it takes them, they have to take a half a day out of their work to be able to access some of those services. So when you start thinking about those similar barriers that we have not solved for in the virtual environment, such as making these environments more easy, more accessible, more intuitive, I think there's a lot of opportunity there. And then the other opportunity, which is an upcoming work stream that Impact will be working on next, is how do you work on transitions of care, and how do you work on data flow to really make that user experience easier for that virtual first care? Because it's not just about a shiny interface and an easy to use application on your mobile phone. Aside from that, I mean, that's definitely one part of it from a design perspective, but the other even more critical part is how does that data flow into the rest of that healthcare ecosystem? Because from that patient's perspective, even in a B2C or a direct to consumer model, that patient still has other conditions that they have to interact with payers, they have to interact with other providers, they have to interact with specialists. And so thinking about that, and I'm glad that this team will be tackling that next in the transitions of care this fall, and the next version of Impact and V1C is really trying to think through also of how does that data flow across all these member experiences, so that in each of these different verticals, whether it's payer or provider, that the patient doesn't have to repeat the data, the patient doesn't have to worry about carrying their data. And from our perspective of even what we're doing at Commure, that goes well beyond just interoperability just for clinical data. It's payments data, it's claims data, it's revenue cycle data, it's RPM data. It's all of these elements that in a V1C environment are thought of upfront. And then what also has to be thought of is how does that data flow into the rest of the ecosystem. So from my perspective, those are just some high level thoughts from having been in payers, having been in providers, having been in payviders that I think are very interesting opportunities. And then the last piece I'll talk about just very briefly is digital health companies. So at Commure, we're a general catalyst, we're a startup company. We very much are melding the best of Silicon Valley, along with melding the best of large traditional healthcare systems, large traditional payers, and really coming together to think about how do we really work on that data flow? How do we as a platform company really allow the enablement of a fully integrated engagement layer and data layer to be able to allow unlocking of new applications on top of that and new digital health ecosystem companies on top of that. Our executive chairman and co-founder, Hipaa Taneja, who his previous company that he worked on was Livongo, what he really realized at Livongo, working in that virtual first environment for diabetes, was how do you really enable that for the next 1,000 Livongos? And that's what we are here doing at Commure, is as there is this exponential growth in a very positive way in not just V1C, but in digital health companies, how do we make sure all of that ties back into the broader healthcare ecosystem, whether it's a traditional payer, whether it's a traditional provider, not just for the purposes of better member engagement or better patient engagement or better provider engagement, but also what we are finding as we work with some of these large health systems and large payers, these more traditional systems, is that they also are thinking about their own digital transformations. And they also are thinking about how do we enable V1C, or how do we enable a different aspect of member engagement or patient engagement with a more modern technology stack. So not only is this happening in the digital health space at rapid pace, but is also being thought about very deliberately in the more traditional health system space of how do they accelerate their efforts. So I'm very excited to hear about what this panel has to say. Again, thank you for inviting me, Claire, and back to you.
Yeah, awesome. Such important points here. I mean, I definitely think this deep dive into the over 50 population is so critically important. To your point, sometimes they have one condition, but often they have multiple comorbidities, and ensuring that we're really thinking about how does virtual first care work for them, and integrating them into this process is so critically important. I loved some of the comments as well going around in the chat about people's parents using WhatsApp and engaging experiences there, and sort of how do we translate that? And maybe I'll have a question for the panel later focused on how they've thought about this engagement in this particular demographic. Sarah, I also love one of the points that you made in the beginning, which is that, when we say virtual first care solution, I think we typically think about a standalone company that's sort of the bread and butter of what they're doing. But you're right, we're seeing sort of payers get into this, we're seeing providers get into this space, the more traditional brick and mortar providers get into this space. And so when we say virtual first care solution, we really mean, any place across the ecosystem that this is happening. And we acknowledge that there are a diversity of venues news that can be coming at this virtual first care space, which I think is critically important. So now, without further ado, I want to shine a light for a minute on the incredible resources that the Impact team has put out into the world just this week. So if you haven't had a chance to see these golden nuggets that are out there, I really encourage you to spend some time checking them out. There are sort of three key components in this particular toolkit, the biggest of which is certainly the guide to Payer-V1C contracting, but there's also a guide on payment models and a V1C coding library. So just to give you guys a quick sense of kind of what's where in each of these documents, the guide to Payer-V1C contracting goes section by section on the content and really talks about like, what are the specific V1C considerations? What is the practice that is ideal, acceptable, and to avoid? What should be included maybe in different phases of contracting. Maybe you're starting out with like, let's generate some data and sort of see how this works in my population versus doing the full scale deal. And then also in some cases, we've provided sample language where a particular section could potentially use some help in modeling for the field. There's also the guide to V1C payment models. Outlining how payment models work isn't necessarily novel, but how they actually get tailored in V1C is. And so what we've endeavored to do here is to really sort of take 4 key payment models and really talk about the best practices around V1C approaches that might use these. And so definitely hope everyone takes advantage of that. And last but not least, the coding library. One of the things that came up across many of the discussions that we were having as we were creating these resources was the challenges with the codes. And we've started a whole host of discussions with the AMA and others around this topic, but decided that it would be helpful to just catalog what codes folks are using to get reimbursed. And so this coding library begins to pull all of that together. Also to, incorporate codes that we'd like to be able to use, but that have some restrictions that prevent virtual first care from using those codes. And then last but not least, the beginning of a brainstorm of what kinds of codes we might like to see in the future. And so I really hope everyone will spend some time with these resources and keep us posted on how you're using them. We always love case studies. I do want to acknowledge the incredible group of Impact members that have come to the table to be a part of this, many of which have been at this with us since January and have been around the table really, we had one point where we were meeting weekly and spending multiple hours working through all the different concepts presented in these resources. And I'm proud to say I've been able to work alongside some of the greatest thinkers in this space, some of the most innovative thinkers on the bleeding edge to come up with these resources. And so, Don thanked Jen and I for our leadership here, but I want to in turn thank all of these members who have helped us get there and really been the content experts to make these resources possible. So now, I get to introduce you guys to a few of these members who are going to sit on our panel today. So I'm really thrilled to be bringing this group together, highlighting just a few of the hardest workers among us who really put in time, morning, noon, and night to get these deliverables where they are, and excited to be at the moment where we get to do the most impactful part of this work, which is put the resources out into the world and get to work on implementation, because ultimately this is the goal, right? So before we dive in, just a few panel logistics, still encourage everybody to submit your questions to the Q&A. I've seen a few of them coming through on the chat, so we can capture those there. And then at the end, we'll reserve some time for Don and the panelists to be available to answer your questions, which you can also sort of raise your hand at that moment as well and ask something. So jumping in, I want to ask each of the panelists to introduce themselves, their role at their company, and talk a little bit about, how V1C plays a role in your life. So Joe, do you want to go first?
Yep. Hi, everyone. I'm Joe Conley, and I'm the founder and CEO of Asana Health, which is a virtual first gynecology clinic. So V1C obviously plays a role in my life because I'm the founder of a company that provides this type of care. We focus on benign gynecology conditions like endometriosis, which is a condition that greatly affected my family, my mom, my aunt, my grandma, and I've seen firsthand how gaps in care can exist in the brick and mortar world that can be closed with virtual first care. And that's what we're trying to do with Asana.
Awesome. Lucia, do you want to go next?
Sure. Good morning, everybody. Lucia Savage. I'm Chief Privacy and Regulatory Officer at Omada Health. Omada has been providing virtual first care. I think our first patient crossed the transom in 2013, but Sean will ping me if I've got that wrong, for a very long time. And we're currently focused on creating really a virtual diabetes clinic.
Perfect. And Marcus.
Sure, Claire. Yes. And before I get started introducing myself, I want to just thank you and Jen and folks from the ATA and Don for putting this together. You just so proud of the work you've done and so appreciative of being able to be part of it. So I'm Marcus Tygeson. I'm the Chief Health Officer at Bind Benefits. Bind is a startup health insurance company, and virtual care is a critically important part of our clinical strategy. We're all about helping our members find high value care and save money and for themselves and for their plan sponsors by choosing high value care. And virtual care does a number of things, including improve access and also improve the quality and outcome of care through the new care models that virtual care enables. And I think the kind of work that Joe and others are doing is emblematic of that. So it's been a very important part of our strategy, and we've been looking for ways to scale it more rapidly. And the work that you folks have done with Impact is really helping that a lot.
Awesome. Awesome. Thanks so much, Marcus. All right. I'm going to stop sharing slides so you guys can officially see our faces for this discussion. I'm going to ask each of the panelists to talk about a particular section of the guide to contracting that is going to help you solve a problem. And if you can talk about that problem and maybe talk a little bit about kind of the work in the guide that actually helps us address it, that would be great. So I'll mix up the order here. Lucia, do you want to go first?
Sure. I think there are two things that have been historic pain points for Omada way before I joined in 2017 that this guide can really help. First of all, there's a lot of, when you go to market and you're pitching your virtual first care to a health insurance company, for example, sometimes you end up with the people who do SaaS contracting. It's kind of this weird thing where because it's software, it must be software as a service. And that's actually not the case. It's really just medical care supported by software. A provider who has an EHR wouldn't end up in a SaaS contract. And neither should a virtual first care company. And I think that is a huge area that having this caliber of toolkit that has had the input of plans and other payers and the companies themselves and some really smart lawyers will really be helpful on. And the second thing is, of course, many on the call know that my passion is privacy and Hipaa. And I think that that's the other thing this solves, right? Not all solutions that are supplied through an app are actually wellness business associates. And we know this historically, doctors made other doctors their business associates. It was a mistake. You ask anyone in this space who does this work legally, they'll go, oh yeah, we've overpapered that. And here the toolkit really has some great use cases and some great standards for all the parties involved in a negotiation to really understand that it is medical care. It is a provider. The provider is a covered entity, and then the analysis just flows from that.
Yeah, absolutely. I think that's such an important point, and really the cornerstone of all the guidance that you'll find in the guide is really hinges on this idea that these are covered entities. They are providers, and they have all of the same responsibilities that a brick and mortar provider would have. And I think, if to the extent business people can educate the contracting people within a payer on that then helps really open up a lot of the things that follow in the contract. So that's a really important point. Joe, do you want to go next?
Yeah, first, I would just absolutely echo everything that Lucia said. And those are major impacts that you can actually have in terms of what the data rights are, what the contract actually looks like, whether you have to undergo a business associate agreement, whether you have to undergo a security review. And I think the reason that that's so important is it can really drive long contracting times. And anything we can do to shorten the contracting times and shorten the administration on the health plan side of things, I think can rapidly increase the adoption of virtual first care solutions. So I think Lucia's spot on there. And then the other thing that I would say about this type of contract is I really like, or the toolkit, is that it really has a wide variety of options that you can adopt for your individual payer provider contract. And so, Claire, I think you have done a really great job putting together the different options for each individual component of the contract. And you can really bring that to discussions with health plans if you're a virtual first provider. And just to give you a little bit of sense of that, I think sometimes health plans can get into we did this way, or we did this one contract this one specific way, and we want to start to replicate that, and it can create some barriers. For instance, if a health plan has always done eligibility file transfers in order to confirm eligibility, then they might assume that that's the way that they need to do it with every other health plan, or excuse me, with every other virtual first provider. And I think what this contract allows for is you can actually come up with creative solutions like 270, 271 eligibility checks, which then allow you to bypass that eligibility file transfer and can actually help you create some really novel solutions that can meet your specific contracting goals with whatever you're trying to do between the virtual first provider and the payer.
Absolutely. Absolutely. And I think that piece of it is so important for even for the next work stream we're going to be doing, right? Where we talk about like, what is the user experience and how does everything flow between the two parties? So I feel like this, and this is how someone gets started on a virtual first care solution. So it's an important first step here. Marcus, do you want to go next?
Be happy to. Yeah. So as you know, Claire, I love the whole thing. And my hope for this process was that it would create a standardized but flexible set of content that would accelerate adoption of virtual first care. And not only adoption, but also innovation, because I think virtual first care is actually the most exciting thing happening in healthcare today. And I'm particularly excited about the ability of virtual first companies to innovate around the care model and deliver qualitatively better clinical outcomes. As a doc, that's perhaps my highest goal. And I think, when you think about new industries, when people first start to innovate, they have all these different things they're doing and they're not standardized, and you have competing systems, and it slows things down. And then you have the health plans, for instance, that are used to contracting in one of two ways. You're either a vendor or you're a traditional brick and mortar provider. And so virtual first care is like a different entity, and a health plan naturally devolves to either trying to treat you like a vendor or treat you like a brick and mortar provider. And if you don't fit, you end up in this long, difficult process. So my hope was for a product that would allow for standardization to accelerate innovation, but allow for the flexibility so it would be broadly applicable by multiple stakeholders in the field. And I think that's what we've got here, and that's why I love the whole thing.
Awesome. My next question is sort of, how are you planning to use the resources at your company? And I think specifically, what others in your company, what other functions are you planning to socialize this with? And Marcus, maybe you can talk a little bit about how you plan to take the whole thing internal at Bind Benefits.
Sure. Yeah. Well, so I have been working very closely with my colleagues on the network side of Bind in the work on this. My colleague Matt Chalk in particular. And we've both been starting to apply it at Bind, but we're now actually part of United. Bind is now a subsidiary of United. So I'm looking forward to actually taking this work and introducing it to, or spreading it more broadly with the United folks, their network folks. Optum has been a participant in this. I'm looking forward to partnering with them on this so that we can accelerate our ability to contract with virtual first providers and get them into our network and offer them to our members, and or leverage United's capabilities and take advantage of their capabilities to spread this model and scale this even more rapidly.
Awesome. That's perfect. We are behind you and with you as you take that forward. And I think, our hope is that we can replicate that across many of the large national payers, as well as some of the smaller kind of regional groups, not just UHG and Optum, but others, and really sort of see adoption happen in that way. Joe, do you want to talk a little bit about how you guys are planning to use it at Visana?
Yeah, so I would contrast Visana compared to Lucia and Omada that have been around for a very long time and are very well established players in the market. We've had to really try to figure these things out over the course of the last 2-3 years. And the way that I've gone about doing it is piecing together multiple different conversations from people who were kind enough to lend their help from companies that were, years ahead of me and have really gone through the different aspects of this contracting process. And so I think one of the best things about the virtual care world is that the people within it kind of take a all boats rise type mentality, and people are very willing to help the people behind them solve the issues that they have already encountered. And I think the great thing about this type of contract is it puts forward all the different learnings into the public domain. And so people don't necessarily have to start piecing together all of these different things when they're first starting a virtual care company. And instead, they can go to this resource that really outlines all the different critical components and the different ways that you can go about solving these things. And so one of the things that I'm most proud about with this contract is that it's really democratizing the knowledge that we have as an industry. And to Marcus's point, I'm hopeful that it will accelerate things both on the innovation side, on the virtual first care providers, as well as on the health plan side of things. And so the way that we actually use this is I actually have been referencing it multiple times in my conversations with health plans, even just within the last month, because it helps to bring forth to say, all right, what are the discrete things that we need to be able to solve to really get this implementation off the ground? And how can we start to think of unique ways that we can overcome outreach barriers or eligibility barriers? And it really helps me to be able to find these discrete things that are pain points that are actually holding up the contracting process. And I've recently gotten one contract that I've pushed through because I've used different aspects of this specific contracting toolkit to come up with unique ways to overcome the barriers that my health plan partners were running into. And so I've already seen immediate value in this contracting toolkit, just having gone through this process. And I'm hopeful that others on the phone will also see similar value and be able to accelerate their contracting timelines and ultimately, hopefully reduce some of these 6, 12, 18-month-long sales cycles that have become normal in the industry.
Yeah, awesome. And Joe, I mean, I think it was you who said when we talked about, how should this be presented on the Impact website? I think it was your idea to sort of have each individual section of the contract be linkable so that, when you're negotiating on one particular section and having breakdowns, that you have an easy way to sort of link and say, here's the best practice on this particular section. So our hope is that makes it just easier to take off the shelf and get integrated into conversations, and look forward to hearing how that goes for you. Lucia, your organization is obviously at a very different stage than Joe's organization, so it would be helpful to hear how you all plan to integrate it into your work.
Well, first I have to crack a joke. I would say my commercial contracting colleagues definitely have a few battle scars at United Healthcare, Marcus. So, in a bar sometime, we'll just do some note comparing. And I know Optum is a founding member and they're of course sister companies, but I'm wishing you all the best with that. So how are we going to use it? I think a couple of ways. It's incredibly validating of the effort and investment Omada has put into convincing other people that it is in fact a healthcare provider in a marketplace where our immediate competitors are often not healthcare providers. And so it really gives us an opportunity to amplify that distinction and all that it means for our partner, both in terms of, as a covered entity, how does it work, the longitudinal data, the analytics, all the pieces that go with that, but also in terms of what they can expect in terms of responsibility as a clinical responsibility, privacy responsibility, security responsibility. So there'll be a lot of, see, everyone else does it this way too. I'm sure that will happen. The second thing I think is kind of back to some of the comments we had earlier, that a really important hill that virtual first care still has to climb is serving federally funded patient groups, Medicare and Medicaid in particular. And I think that this toolkit is a really important step on the climbing of that hill. There are many issues to tackle with Medicare, and that may be a webinar for another day. But from my perspective as a person who runs the policy and regulatory portfolio at Omada, this is a really important piece of a tool for me to use when I go to federal policymakers and they want to know, why are we not just a cheesy app that's free in the App Store? How does it work? And we can say, look, there's an industry organization. We've done this toolkit. We operate just like a doctor's office. That's the message that I really want to drive.
Yeah, that's awesome. And such a great reminder that, you know, when we talk about third-party payers, you know, I think so often our minds go maybe to insurance companies, but, you know, thinking about federal payers, thinking about self-insured employers. You know, we have Mercer as a member in Impact, and that's been a big, obviously, focus of theirs. And I do think there's an opportunity to really think about, you know, maybe there's a piece of work that we need to do that specifically orients this resource or these resources towards that audience, or another, right? And so really making sure that, you know, we've dotted all of our I's and crossed all of our T's to have these resources support across any kind of payer is important, is really important. So this is great. This is really great, Lucia. Thank you for your comments. So my last sort of question for the panel is around how different players across the ecosystem can use these new resources to continue to advance virtual first care. And so this gets more to, you know, Marcus, the different kinds of categories of virtual first care solutions you guys are exploring. For those of you on the virtual first care side, I think obviously the Medicaid programs is a good example, but, you know, just kind of the diversity of opportunity here for the entire ecosystem to take advantage of these. I'd love your comments on that. Joe, do you want to go first?
Yeah, absolutely. I've touched on how newer virtual first providers can really use this as a tool to accelerate their go-to-market strategy. And I absolutely think that that's something that we should be pushing forward for. And in the grander scheme of things, I think ultimately, like Marcus alluded to, what all of us on the phone are trying to do is improve patient outcomes, improve access, and lower costs for patients. And I think virtual first is a very important modality to be able to achieve those goals. And I think if we as an industry can all row in the same direction and say the same things, then it behooves all of us to take the exact same stances so that people start to learn the truth about what virtual first care is. And to Lucia's point, the fact that we are just a virtual provider and you should treat us just like you would a brick and mortar provider from a contracting perspective. And I think what would be really powerful is we all start to use similar resources and take similar stances. And then the industries can start to coalesce around these truths. And we can really start to reduce some of these go-to-market times on the virtual first provider side. And on the health plan side, I'm sure they also like to have ease of administration, reducing contracting fees. All of those types of things are very helpful as well. And so I think this is a great resource to really try to advance that goal as an industry and start to improve access for patients wherever they are, be it rural or urban, whether they have access to multidisciplinary integrated care. Those are all goals that we can start to achieve using these types of resources.
Awesome. This is so great. And I think so critically important. Lucia, do you want to comment next on this one?
Sure. So I'm going to go back to something Don talked about, which is scale. So in traditionally, there are some really, really large hospital systems, but they are not nationwide and they're not in every 50 states. And by the way, 6 territories, so 56 locations. And virtual first can really hit that scale. And if you can make the case, it's, to me, obviously reducing time from I want to do this to I've implemented this is important. But I think what's more important is this. When you contract with a virtual first provider and that provider can operate at scale, then you have a provider who is operating at scale. As a payer, you have this person or this organization in your network for all the people that you want to offer it for. And I think that's a really important point because it improves the insurance company or the payer's rollout of this service, right? And it doesn't matter whether you're a large self-insured employer, you want it for everybody you have everywhere. We get that all the time from customers. Can you do this thing in this location? You know, and it might require translating some regulations if it's Puerto Rico, and it might require checking on, you know, the Wi-Fi if you're in one of our Pacific territories. But that's the key. I want this everywhere for everyone I cover because I think it's good for everyone. And the humans don't change across the territorial lines, just all the complexity of the contracting. And so that's what I would really like to drive, and how I'd really like to see this used, is to help us get to these incredible health improving benefits at scale.
Yeah, absolutely. And I think Sarah talked about this as well. Like there, you know, I think the naive view on this is like, oh, it's tech enabled and it's virtual, so we can just scale it up to everyone. I think, Lucia, you point to some of the ways, and Sarah talked about, you know, Wi-Fi access and those kinds of things being, you know, new barriers that present themselves, right, in this care. And so I think it'll be critically important, obviously, that you know, we focus on the good, and we attempt to, you know, do these deals and scale these solutions because you know, as Joe pointed out, it can improve access, it can improve outcomes, et cetera. But we also have to be smart about how we do that and make sure we're implementing it for success with kind of a whole new set of challenges that maybe healthcare didn't necessarily need to deal with as much before. So I think that's critically important. Marcus, do you have anything to add here?
Oh, well, I hope so. Yeah. You know, I think actually there's another group of stakeholders who I think will benefit from this work, and that actually is the more traditional brick and mortar providers. The more progressive ones are already trying to innovate in this space, already trying to move to more of a virtual mediated or virtual first practice style for a number of different kinds of conditions. And they're running into challenges in terms of finding ways to contract for those services that make business sense for both them and the payer. So I think there's going to be value created there. And then my last comment is that I'm very excited about the pro-competitive effect of this work. You know, I think that the kind of quasi-monopolistic position of a lot of brick and mortar providers in their communities has really retarded innovation in healthcare. And I think the advent of virtual type technologies that allow for incredibly rapid innovation with respect to care delivery in the virtual first space is going to be a strong prod to the rest of the healthcare system to innovate more rapidly, more effectively. And I'm very excited about the dynamism of that. And I'm hopeful that we're going to see a much more rapid improvement in both the efficiency and the effectiveness of healthcare as a result of it. You know, I think that the landscape of the provider landscape is going to look very different in 10 years than it does now, as virtual first companies take larger market shares of you know, the sort of the front end of healthcare. Yep. And begin to actually drive change inside the more traditional back end. And as the more traditional providers use the kinds of tools you guys have created to begin to innovate themselves and move more rapidly into the space of high value care.
Yeah, absolutely. I think it's a really good point. I mean, we're fortunate to have Ochsner Health System as one of our members. And of course, they've been really leading the way with their virtual first care solutions. I actually just saw an article, a Q&A they did with the American Medical Association a few weeks ago, focused on their goal to get to 50 states plus DC in the pretty near term, which is incredible. But I think, you know, that's probably more the exception than the rule for providers. And so this is why I think this next work stream that Sarah sort of alluded to is going to be so important, because you know, it's patients are going to use these as sort of front door integration into their everyday life in terms of their care management. And it's important that then when they walk in to see their PCP or, their specialty physician face to face, that virtual first care is viewed as a complement, not an annoyance, right? And so how do we ensure that those patients show up at the same time, either the data that's been collected on a virtual first care solution also shows up, whether the patient brings it or it's piped in some other way, and that the experience for both the healthcare provider as well as the patient in that moment is a positive one, because ultimately, we're taking better care of patients here, we're driving better outcomes, and so we want to make sure that the experience aligns with those positives. So I think this is going to be so critically important. So this is awesome. And I think such incredible conversation around these key issues. I do want to open it up now to Q&A. So if anyone has any questions, feel free to drop them in the Q&A or in the chat. I know there have been a few that have come up already that I do want to talk about. So Jerry Blombat had asked something about co-design and testing with seniors. Jerry, if you're on the line and in a place where you're able to unmute and speak, it would be helpful to have you sort of ask your question aloud, and if there's any context you want to give, and then we can have the panelists respond. Jerry, are you there? Oops, maybe we don't have Jerry live. So for the panelists, do you guys mind talking a little bit about how you guys have thought about co-design and testing with various audiences, including seniors?
Sure, I'll take a stab at that. So Omada actually in its earlier years was given an investor specifically requested that we develop an appropriate product for the Medicaid population. And so that included actually a very deep dive into health literacy, bilingualism, how do we, and co-creating through discussions with people from that population. And that's all actually reported in a peer-reviewed journal. What I'll do, Claire, is when I'm not trying to multitask, I'll make sure you have the link to that and you can send that out to other people in the org. And then I think that is also true for seniors, right? And for anyone who has a different ability. And so I think ADA compliance and 508 compliance is really important to think about when you think about a virtual first care interface, because people have a lot of different needs, whether it's visual or hearing, that run across the age gamut. And then finally, our work with the Medicare population, we definitely are getting feedback from our seniors all the time. We are working desperately to be a regular supplier to the Medicare population. That's a story for another day, but we have had some pilots that have provided us with great feedback that has then informed our own standards for health literacy and design, which really peg 8th grade education.
Awesome. Joe or Marcus, anything to add to that?
Well, I actually was going to say a little bit about co-creation between virtual first providers and health plans. Different from the other thing that Lucia was commenting on, but another thing I've seen sort of legacy contracting between payers and providers is we're going to sign a contract and then we're going to provide the services and then we'll evaluate 5 years from now when we finally have enough data and then we'll make some decisions about what to do. And I think actually that my hope for some of this is that we move in a much more dynamic way, that we have a contracting process that allows us to get started with in pilots and then learn from the pilots and adjust the contracts based on that experience so that we can move more rapidly to kind of a value-based pricing. And that, in my mind, involves payers and providers actually collaborating to figure out how do we work together to maximize the value created here, maximize the health outcomes and maximize the cost reductions that we can generate through this kind of partnership. And that's a very different way of working together. It's really a strategic partnership, and not the kind of arm's length transactional relationship that most payers have with most of their providers. And I think, frankly, that applies to even most ACO type relationships as well. I think Virtual First actually enables that kind of relationship, because you can provide comprehensive, or you can provide a lot of comprehensive, especially ambulatory care to a nationwide group of people with a much smaller set of providers than you can if you're only using brick and mortar providers. So the potential to have a small number of very strategic relationships focused on improving performance with Virtual First Care, I think, is a powerful incentive to that kind of model. And I think the adaptive contracting approach that you guys are kind of modeling it with this toolkit is going to help that.
That's great. That's great. I want to go to Mark Jomokowski now. I'm gonna allow you to unmute, Mark, if you're willing to ask your question live, because I think this is a really important one.
Hi. Yes, I was just curious to what extent the conversations you've had internally have also bridged into the regulatory space, because as health plans go about creating their networks, setting things up, there's geo-access standards that have to be attested to. And to what extent the Virtual First contract actually addresses what some of those mandates are. To what extent you've had those conversations. And then the follow-on to that is, in terms of value-based contracts, to what extent the same type of regulatory oversight and review of those types of contracts has been part of your conversation. So it gets to, in essence, replacing the traditional brick and mortar physician office with a virtual access, but to do so in a way that also meets the regulatory requirements that health plans often face.
I'll take a stab at that, Claire. And the toolkit talks about this at a very high level, because depending on the model of the Virtual First Care provider, they're clearly going to have issues of, are their professionals licensed to serve the people in the state where the resident is? And that's a core part of it. And a health plan rightfully is going to demand that you make a legal promise that that will always be true, because that's what the law requires. So that's kind of baseline. If you're going to be a provider, you have to meet the laws, like, period. But I would say on top of that, I think that there are obviously, what Mark is referring to, there are many other geolocation issues. For example, density and availability and drive time. And are you in a rural or suburban? Arizona, I think, has 4 different categories. All of that is really complicated. And I wanted to separate the licensing geography from the availability geography. And then I would say on the latter, certainly at Omada, we track where our equipment works and doesn't work. And so we know, because of the data science, what's working and what's not. I think it's an important thing for Virtual First providers to think about, which is it Bluetooth? Does it require 5G or 2G? Like, what is the technology that is required to make sure the patient can get to you? If we do aspire to serve, for example, the veterans who live in rural communities, or the health disadvantaged people who live in rural communities, then our equipment has to work there. And so that's on the Virtual First Care company to really be able to stand by its technology in that way.
Super, super important here. Yeah. So John, John Waldschwitz, I'm going to ask you to unmute if you're able and ask your question live around the best practices we recommended around the SOC 2 and the high trust compliance challenges. I think this one is a good one, because we spent a lot of time on it.
Yeah, hi, thanks everybody. So the question I had was, we are targeting 2 different groups of people from a commercial standpoint. One would be the payers, such as like Cigna, United Healthcare, et cetera, and also some IDNs like Kaiser Permanente, Cleveland Clinic. And what we're curious about is, we know that the large payers will require high trust certification, but as we move on that journey, is there benefit to SOC 2, and are there I should say maybe less specific requirements for the IDNs.
I can chime in here, and I think this goes back to the point that Lucia was making, I think towards the very beginning of this panel, to say that payers should be treating virtual first providers just like they would brick and mortar providers. And so we take the stance that we are a covered entity, and the data that's generated within the VASANA program is PHI that VASANA owns and for which we are liable for. And so if there isn't any data transfer between the payer and the virtual first provider, then there might not need to be a reason to enter in a business associate agreement, because we aren't receiving data from that specific entity. And so I think there's two main streams of data that you might be receiving from a health plan. The first would be the eligibility data, and we've identified ways that we can get around that by doing 270, 271 checks. The second is outreach data to make members aware of the new provider that's being offered within their network. And if those two things aren't being transferred to the virtual first provider, then you might not need to undergo a security review. Now, whether that's actually happening today in the real world is a different story. And I think what we've seen is that I definitely agree that payers are moving more towards high trust certification, but I think at the earlier stages, which is where VASANA is at, is if you're able to show that you're engaging with a security auditing firm and you're thinking through how you're going to go through Hipaa to SOC 2 to high trust, then that's kind of the road that you want to be able to put on and show a roadmap that you have towards moving towards those goals. And in my experience, SOC 2 is very helpful in being able to be a stepping stone towards high trust.
I want to just jump in there. I would say early on, 5 years ago, Omada made the decision to acquire both high trust and SOC 2, and I dropped the 2018 press release in the chat because we believe that having demonstrable high grade security controls is actually important to our brand. You've got to decide that for yourself within your own companies. But I would also assert, maybe a little bit differently from Joe, if you're a provider and you're not achieving the highest security standards for data that you're collecting directly from your patients, shame on you. Shouldn't matter that a payer is making you do it. You should do it because it's the right thing to do for your patients. The security in the healthcare system is weak in many locations, including the small brick and mortar practices. And I like to be able to say to patients, actually, we do this, and it may be better than what you're getting in a brick and mortar setting. And then the last thing I'll say is, it's no joke. Even if we can convince a payer that we're not a SaaS vendor, that we're actually a covered entity, then we have to deal with their counsel, who may understand that at a legal level, being aligned with their security team, who may just see a nightmare of digital data that is going to come home to roost to them legally, even though they're not actually responsible for it under the hood. But you have to think about your payer partner and what it's going to look like for them if you have an error that comes home to roost in their inbox.
Yeah, critically important stuff here. And I think a really great question. Thanks, John, for asking that. So Reza, you had a question, and I'm trying to fully follow it. Let me give you the opportunity to unmute and ask it here around virtual first care services being offered through PCPs and specialists, as opposed to kind of larger healthcare organizations.
Yeah, thank you. Great panel and great session. Just briefly, at the one end of the scale is the access to users, but the other end of the scale is having providers be able to deliver services. And as successful as a company like Omada is, it still is not big enough to address the number of providers that are needed to, let's say, offer services for diabetes. We're going to have 100 million diabetics in the US alone in just 5 years. So how do we how do we provide an infrastructure to let's say diabetologists or primary care doctors to offer V1C services through channels that are not monopolies once again?
I'm happy to take a stab at that. So what we've heard from the physicians in practice is they love our product, but they cannot be confident that there's insurance coverage for it. for their people. So that takes us all the way back to the beginning of this conversation, that if you're a national plan and you include an Amada or one of our competitors as an at-scale provider, the same way all the diabetologists are included in your network, basically at scale, but you've done a contract in each state, then if the physician can say, wow, you should really try Omada or Teladoc or whoever it is, and I know you'll have coverage. And that's the place we are at, and that is a key, hopefully a key benefit of this toolkit, which brings us to the place where virtual first care is not, coverage for it is not dictated by who your employer is, but it's really at the plan level as a provider. That's where I'd like to have it go, because I know that the diabetologists and the endocrinologists and the nephrologists and all the specialists dealing with the very, very sick people with diabetes want their less sick people to have these solutions available, and coverage is an issue.
Thank you.
Perfect. I don't know if anyone has any other questions, or panelists, do you feel like there's anything that we haven't covered that's worth saying here? Awesome. I think we've done it. I think we've done it perfectly. This is great. Well, I want to end with just one last slide here that gives everyone some take-home actions. But before that, I really want to thank our panel. Don, I want to thank you as well for joining us for those open remarks. This has been an incredible journey. I think we started in May, and maybe Marcus looked at me and said, do you think we could have something ready by the end of June? I need it. And I said, I'm going to try, but that seems unlikely. And it took us, we went 2 months longer, but we still moved pretty quickly. And I think the end result was the right way to do it, or at least I hope it was. And so I really appreciate all of your and all of the Impact members' contributions to get us here. It's just been an incredible journey. I hope everyone on the line will join us at Impact in one way or another. So you can access the toolkit through the Impact website, which is here on the slide. If you're interested in joining us and being a part of this community, we are the home for virtual first care. We want to be virtual first care solutions. We want to be payers. We want to be virtual first care component providers, different services. We have some lawyers, we have some consultants in the mix. And so this really is meant to be sort of the congregating ground for virtual first care. Sarah talked a little bit about what our next work stream will focus on around transitions of care. How is the data going to flow, and what is the user experience vis-a-vis all the venues of care, and the flip between the payer and the virtual first care solution back again. And it will be critically important for us to have a well-rounded set of perspectives at the table for that. And then last but not least, sign up for our newsletter. We do put out sort of a recap each month of the news and what our members are up to, but also more broadly, the trends going on in the field. And so encourage you to follow along there. Awesome. Well, thanks everyone. I hope you have a great rest of your Friday and a great weekend. And we appreciate you all making time to be here.